Okay. All right, shall we get started? I think I'm going to get started because a lot of it is the intro stuff, and then everybody will hopefully join while we're talking. So John, if you could get the slides going, that would be fantastic. Thank you.
Hold on just a second.
How's everybody doing? Getting ready for the holidays already? Not yet, huh? It's not even, I think Christmas is coming before Thanksgiving or something. I'm not sure. Looks like it from the stores. Okay, thank you very much. Okay. Anyway, I'm going to start anyway, and I'm sure that the slides will come up for us as we get along. But thanks for joining. And this is our monthly echo, where we have a chance to get continuing education credits. We learn from each other. We share our challenges. We share our joys. We share our great ideas. And we do it all from the convenience of our home. And and it's free. So I'm glad that you can join us. Great. Next slide. And the next slide. And of course, if you do share about your patients, don't share their names or their birth dates, and the questions can be anonymous. This is a safe place for learning, and these are not official doctor consults. This is just for teaching purposes only. Next slide. Okay, these are Zoom logistics. I'm sure you guys have figured this out by now. There's a chat box at the bottom of the screen, at the bottom, and you can enter your name and other people joining the session in the same room with you. So you can put those in there and we will know who's here and keep attendance that way. There is a mute button at the bottom as well. So make sure it's on mute when you're not speaking. And when you speak or have a question, you can unmute to do that. Next slide. Okay, this is our calendar, and right now we started our depression series, and today we're on number 2. We're going to talk about medical treatment for depression. Next slide. Okay, this is just to let you know you can receive certificates of attendance as well as CMEs and social work credits. So there will be a link in the chat box towards the end of our session, and you just click on that and you respond to the evaluation. Next slide. Okay, now just a little bit introductions. I'm Dr. Wen. I'm the course director for this series. And we have other people on our hub team. Wynette unfortunately cannot join us today, but I'm sure she's with us in spirit. And Maribel, want to say hello? Wave hello.
Hello, everyone. Hi, Dr. Wen, and happy Thanksgiving to all.
Yes, great. And Juliana, want to say hi?
Hi, everybody. This is Juliana from Aloha Care. Thank you so much for joining us today. Glad to have you.
Great. And Shane.
Good afternoon, everyone. Thank you so much for joining us. Welcome.
Okay, great. And next slide. And so as we start, we're just going to do a really brief moment. It's our COVID corner with a chance to just do a little bit of updates for things going on right now. Next slide. Just want to, let you know, where are we now? We're over here at the Delta surge. is the second line there. And we are out here, way here on the bottom in blue. And basically want to let you know, see, take a look at this. Our infection rates are going way, way down as our vaccination rates have gone way, way up. And we are like doing awesome for the whole country. Look at that compared to the US, the California, and Vermont. Actually, I wanted to share this with you because it looks like there's another surge going on. And in fact, there is a surge going on that's starting about right now, and it's peaking in about half of the states in the country. And oftentimes what happens out on the mainland is that it comes to us a few weeks later. So that's what everybody's afraid of, is this next surge over here. Now, it turns out also is that this Vermont is also highly vaccinated, as well as just as much as we are. We are about 72% total population vaccinated, and so is Vermont. And so you're like, oh, what's going on over here? Well, I guess this is the Delta variant, and it's highly contagious, and that even if you have your vaccinations, you can still catch it. And that's the scary thing. You can still catch it and you can still hit another surge. And I think, but it's interesting, if you look at the map of the US, it's really the cold states, the ones that are up north, who are getting the surges right now. Because I think what's happening is that everybody's going indoors. And then they're starting to do all that, I don't know, indoor activities and eating and holiday prep and all that sort of stuff. And so that's kind of what's happening over there. And so we need to still be very, very careful. But next slide. I also wanted to offer a note of hope, is that you see, look at Vermont in the green. You saw how it was really high up there? It's really low over here. You know why? This is the graph of hospital rates. Because even though they're getting lots of cases, guess what? They're not landing in the hospital. Why? Because they have their vaccinations, right? And so that's what I wanted to share. High vaccination rates lead to relatively low hospital rates. So just push for get vaccinated. And you know what? I think that Hawaii is going to do really well this winter, because unlike a lot of the northern states and things like that, we can be outside. We have options. We don't have to be all stuck inside. So I think that if we can play it smart and everybody get vaccinated and do all of our visiting outdoors, I think we'll be okay for the most part. Next slide. So yes, winter surges. So the other reason why there was another Delta surge going on in the country is because of waning immunity. So what does that mean? That means that your immune system is it's not quite as strong as it was when you first got your shot. And 6 months later, it needs another boost, so to speak. And so they're finding that getting an extra booster will help you fight this thing much more effectively. You won't get infected and you won't get as sick. So that's the thing. So get your booster shots before the holidays as best as you can, and encourage everybody to do so. Next slide. Okay, just a little bit more updates on immunocompromised people. Again, I showed you last time, but immunocompromised people refers to folks with organ transplants, immunodeficiency diseases like AIDS, HIV/AIDS, blood cancers like leukemia, people with cancer on cancer treatments, and other people on immunosuppressive medications for one reason or another, like rheumatoid arthritis or things like that. Next slide. Okay, and so this is the updated slide for that. So first dose, get it as soon as possible. Second dose is 28 days later. And then third dose, this is an additional primary dose, also 28 days later, although Moderna is the lower dose. And then for immunocompromised people, there is a fourth dose booster 6 months after the first three. After the third dose is 6 months later, and that is recommended for people who are who have those special diseases I mentioned earlier. And if they are on immunosuppressive medications, you need to hold those medications for 2 weeks after the vaccine. Otherwise, your vaccine is not going to work as well. Your body won't be able to mount that response. Okay, next slide. And then this is an updated slide for persons at high risk. And if you notice here, there is a pregnant lady, which wasn't there before. And we're highlighting this because there was a lot of hesitancy for vaccination for women who were pregnant. But you know what? There's been a lot of studies, and it's really showing that pregnant people are at high risk as well. And the risk of that is that, you know, the mother and or the baby may die from COVID or really suffer really bad consequences, which is kind of the worst thing. And then the side effects of the vaccine are relatively minor compared to the very bad consequence of not getting the vaccine. So just want to highlight that this is a person at risk. So any of your staff who's pregnant, any families visiting, things like that, they can get vaccinated. I would encourage you to encourage them. Next slide. And so this is the vaccine booster shots for high risk persons. Those are the ones that I just showed a picture of. First dose, get it as soon as possible. Then the next dose is 28 days later. And the third dose is what they call the booster dose, which is 6 months later. And as in before, the Moderna third dose is a lower dose. It's half the dose. And then Johnson & Johnson has a totally different time frame. Basically, after the first dose, the second dose is 2 months later. And, you know, mixing and matching boosters is okay. Next slide. Okay, also want to let you know it is also flu vaccination time. So flu shot plus COVID vaccine, please get both. There's a lot of respiratory illnesses going around out there, including flu. Next slide. Okay, so I guess the holidays are upon us. And so I wanted to just underline the fact that we need to celebrate safely. We want to encourage everybody to celebrate, but do it safely. So if you notice, these guys, they're all outdoors, and that is a good thing. And look, they're all wearing masks, and that's another good thing. And you know what they're talking about? Vaccines, making sure everybody's vaccinated. This is really the best scenario if you want to make sure everybody is as safe as possible. So please wear your mask, even if you're vaccinated. That's always the safest thing. But you know, if you're outdoors, the wind is blowing around, it'll kind of blow a lot of the viral particles and infection away. But that's why being outdoors is safe. Next slide. Okay, and so we really want to encourage you. This has really been a rough year, 2 years, year and a half, and we really need to take care of ourselves, take care of those people in our facility, take care of our residents, take care of our staff, take care of our family and friends. You know what? We've had enough of social isolation. And I think at this point, we've learned enough to know that we don't have to be socially isolated. We can be physically distant without being socially isolated, because social isolation is not good. Next slide. So just wanted to give you some ideas from the Alzheimer's Association and some other references. Actually, I left a whole bunch of tips. If you go onto our website, under the resources section, there is a whole ton of resources the Alzheimer's Association gave us. And you can just click on each of those and take a look at them. So lots of good ideas. But this is one about tips of making holidays more enjoyable at a care facility. So anyway, this is just some of the stuff I'm going to highlight. You know, celebrate in the most familiar setting. You know some of this already, because you know that changing the environment sometimes causes distress, and you can maybe hold a smaller family celebration at your facility. It might be less distressful than having them go out. And safer too than having them go out into the community or into the home. And you might actually, you know, participate in holiday activities planned for the residents in your facility as well. So if you hold something, you invite some of the family members, maybe do it outdoors, something like that. Minimize visitor traffic. So maybe, you know, you have to schedule everything, time it so that not everybody drops in on the same day and everybody has staggered times and staggered days. And because large groups are overwhelming anyway. And to prepare visitors, right? We have to let them know ahead of time about any changes in behavior or memory since their last visit. Some people only visit during holidays, you know, they fly back from the mainland to see their grandma or something like that, right? And so providing them a recent photo and help them prepare for changes in behavior or appearance or anything like that. Also teach them and suggest ways they can communicate well and expectations like, you know, don't correct errors and interrupt them and things like that. And of course, suggest and provide activities such as, you know, bringing a photo album or something like that. So a lot more on the website. Next slide. And the other thing I really like, this is actually not from Alzheimer's Association, it's from Dementia, I think it's North Carolina. They did this thing, 12 days of holiday caregiving. So I just wanted to just highlight a few of these, right? We get caught up in all the tasks, but we forget to actually enjoy it. So create moments of joy for each resident. Record those memories. So if you can make it last, you can talk it up beforehand, build the excitement, then take lots of videos and pictures and then show it to them afterwards. So the holidays last even longer. You can stretch it out and stretch out the joy. Be open and flexible. Make sure that, you know, just adjust expectations and don't forget to rest. Help loved ones connect. So doing less talking, more doing. Activities, looking at photos together is a really good one. Those are ways to connect. Next slide. Do less, don't do more, because we're tempted. There's always more to do, isn't there? But focus on what you enjoy the most. What is the most meaningful part of the holiday that you want to focus on? You know, which dessert is it? You don't need 5 desserts. You just need one, right? Maybe that's the best one, you know? Maintain your social life and make sure you connect with your support system. Sometimes, you know, holidays can be particularly hard. So make sure that you reach out to the right people, the ones who will actually help you feel more supported. And, you know, holidays is a time people actually step up to the plate sometimes because they want to do something special. So ask for help. Find volunteers and other families to help with holiday events. If you find families that want to do something, decorate something, bring in whatever, you know, take the help. Okay, unlock past memories, include past holiday traditions and invite them to help. So if for somebody, you know, it's decorating gingerbread cookies, and that's the thing that was the defining thing for the holiday for them was cookie decorating, then that's the activity to choose, right? Just figure out that holiday tradition, unlock that joy. Have them participate in whatever way they can. Next slide. 9, bring the party with you. So coordinate your party, right? So it doesn't have to be a big crowd, just coordinate it so it's small, frequent, short visits, spaced out between other residents. Small doses, right? Less noise, more quality time. And you know what? They don't have to just celebrate on one day. They can send frequent cards, they can send pictures, they can send goodies. Maybe they baked something or send videos here and there, right? So if the granddaughter had a piano recital or something like that, right? Or they sang something at the school, right? Video it and send it. Downsize the decorating. Maybe too much rearranging and decorations could be confusing. Maybe just keep it basic, but simple, basic and good, but essentially there. Like if it's a Christmas tree, that's the one you need to do. Accept the gift of support, right? Enlist others to help with all the extras. It's the extras that make things extra special, right? But maybe you don't have to do all that. Next slide. Oh, yeah, and that's it for the 12 days of caregiving. Oh, so actually, I'm just gonna go back to the 12 days of caregiving. I'm gonna open it up to the chat. And you guys can also unmute, and I'll give you a few minutes to talk about any ideas you have for the holidays for yourself and for your residents, anything creative that you have, or any questions that you want to hash out and talk about. Anybody? planning anything for Thanksgiving?
Hey, Dr. Wan, this is Shane. I'm planning on taking the family out to the play in the water. Go for a
Oh,
kayak or a surf or something.
sounds fun. Anybody else? And it's okay if you don't want to do anything either. You say, oh, I don't want to do anything for Thanksgiving. I want to just relax and buy takeout. That's cool too. Enjoy family time. Great. We have to make sure we take care of ourselves and each other. Anybody else going to be taking care of themselves? Too tired to prepare for Thanksgiving, right? So yeah, no need to cook then. Maybe just take out. Buy a pie. Maybe that's all we need is one nice pumpkin pie.
When the pie, there was on the news last night that the pie will be expensive.
The what?
The pies are gonna be expensive this time.
Oh,
It was
really?
on the
Oh,
news last night.
really? Oh
Yeah.
dear. Okay. Well, okay, never mind the
So much,
pie.
so much for that.
Oh no.
So I think, yeah, take out and just enjoy it with the family in house and just kind of just relax. I think a lot of people are getting used to the fact of calling in Uber Eats or stuff like that nowadays, that you just don't feel like you're not motivated to cook anymore.
That's true. Yeah. Different kind of Thanksgiving. That's fine.
I
And you know what?
know.
Just blame it on COVID. That's
So
fine.
yeah,
Yeah, you
blame
know
it on
what? It's
COVID.
not safe. I'm just doing Thanksgiving simple.
It's laziness. That's what it is.
Just blame it on COVID. You can be lazy. I give everybody permission to do that. Sounds good. All right, next slide. Okay, so we're going to talk a little bit about getting help for depression. Remember, poor ER, he's really sad. Next slide. And, I want to say thank you very much for screening your residents for depression and for sending in all those responses. I know that was a little extra and you guys rose to the occasion, and many of you did do that. And we'll show you some of the results later at the end of the slide. But yeah, remember this guy, this ER, right? He had a PHQ-9, little interest for nearly 3 days and feeling down for 2 days. And if his score is 5, which means that he has major depression, and we need to talk to the doctor and let them know. So we'll figure out what we can do to talk to the doctor. Next slide. Okay, so, who's this? Is this a bumblebee? Is that a bumblebee, or is it Eeyore? Right? Or is it in disguise? So the point is that depression doesn't always look like depression, right? Sometimes, so if somebody has, lack of appetite or poor sleep or fatigue, maybe it's actually due to medication. Maybe it's a medication side effect, right? Or maybe they have a medical illness. If they have some trouble thinking and maybe some hallucinations, it might be some delirium. They have an infection of some kind, a cellulitis or skin infection or urine infection. Or maybe they have thoughts of death. Maybe they're just grieving because, a really close friend passed away, right? Or maybe they have lack of interest and maybe it's due to something else, right? They're just tired because of another medication, right? Or tired because they have thyroid disease, right? And so depression can be disguised, and that's why we need to tell the doctor so the doctor can do a thorough medical evaluation and make sure they rule out all these medical illnesses. Next slide. Okay, so that's why it's important to let the doctor know. And the doctor will do a longer test. The PHQ-9 is the long version of you did the PHQ-2. And the doctor will also want to review their medical problems and their medication list. So the full medication list to make sure there's nothing in there that could possibly contribute. And they'll also ask you for other observations. Like I mentioned before, are you noticing that they're not sleeping as well or having trouble thinking, more agitated, more aggressive, thoughts of death, or things like that. So they're going to ask you for all these types of things that maybe you've noticed that has been different. Next slide. And so this is the PHQ-9, the long version of that PHQ-2. And there is actually an item down here called thoughts that you would be better off dead or hurting yourself in some way. This is what we call suicidal ideation. That means they're thinking about suicide, which is terrible. Next slide. And so I think to better understand it, we can look at who actually chooses to do that. Well, go ahead and click, yeah. Who completes these nursing home suicides? So I think care homes are very similar in terms of the types of patients. So what people did, they looked at all these nursing home residents, they found that most of them are male, who are with the mean age around 76, and who are not as demented. They're more cognitively functional. So that means they can think enough to be able to plan something. All right. And most of them do it within 12 months of moving into a care home of some sort, right? Because they had to leave their home and maybe they're feeling hopeless or something like that. And so usually that happens within the beginning, the first 12 months. And how do they do it? Most of them, the larger numbers, do it by hanging or falling from a height. That means they walk off the lanai or they go out the window or do something, fall down the stairs. They fall from a height. Cutting, asphyxiation means they maybe put a plastic bag over their head and, do it that way, or drowning in the bathtub or something like that, or save up some medications and then take an overdose. And what else? They're associated with physical health. So people who are declining, 50% of them have decline in physical health. They cannot do the things they used to be able to do. And a lot of them have depression. Majority have depression. And in particular, what I want to point out is that 62.5% of residents diagnosed with depression not receiving any pharmacologic treatment at the time of death. So the people who are not getting antidepressants to treat their depression, those are the ones who tend to commit suicide. So, this basically tells us that, yeah, we really have to take this seriously and prevent this. Click some more. Yeah, we can prevent it. Click again, right? How? By making sure they don't have access to the things that they can, make sure they're watched 24/7 so they don't, walk off somewhere dangerous and fall from a height or be able to plan something like plastic bags or knives. Next, click. Okay, and for depression, making sure that if they really score high on their depression, that you need to get them help and get them treatment. And majority, interestingly, had no prior suicidal behavior or attempts. They never did this before, never thought of this before. This is new for them, and these are in their old age, right? When they were younger, they weren't feeling this way. So this is kind of the picture of those who might want to consider suicide. That's why we need to treat them seriously. Next slide. Okay, so yeah, it takes teamwork to treat depression, right? So there's the patient, there's the doctor. It's not just the patient and the doctor, right? It's you guys, it's the whole team, it's the whole family, right? And we talked a little bit about suicide prevention. John, can you click? Oh, okay. Whoop. Yeah, that's good. This thing is very faint and we have to fix the font here. But yeah, the doctor might consider getting a psychiatry consult or starting antidepressants. And for non-drug treatments, there's stuff like cognitive behavior therapy and behavior activation, which includes things like changes in activities and environment. And the thing I also want to point out here is what they said over here with ER, here's this is the nursing, this is the care home staff right here, right? They're taking care of ER, that even though he is basically clinically depressed, he still gets invited to participate in all the adventures and shenanigans with all of his friends. And they never expect him to pretend to feel happy. They just love him anyway, and they never leave him behind or ask him to change. So I think there's something we can learn from these guys. All right, next slide. Okay, so there are many different types of antidepressants. If you look at this list, you might recognize a few of these. These are some antidepressant medications that a lot of doctors prescribe, and they're all different. They have different mechanisms of action. They work on different chemicals in the brain, and so they're kind of different from each other. But so I call them different flavors, like different flavors of ice cream, right? And how do you choose one flavor over the other? It's based on their diagnosis and their patient characteristics and their side effect profile as well. So different ones have different side effects. One might increase your appetite, the other one make you more activated, the other one make you more sleepy, and it all depends. So to help choose, the doctor will want to know things like, are they sleepy in the daytime or do they sleep at night? How's their appetite? Are they anxious in addition to that? And maybe we can choose another medication that also helps more with anxiety than depression, So there's different characteristics of these different flavors. Next slide. And the other thing that you need to know is that antidepressants work very slowly. So once a doctor prescribes an antidepressant, it may actually take 4 to 6 weeks to see a good response. Can you imagine waiting that long? That's a long time, 4 to 6 weeks feeling miserable, right? So that's why it's really important to have the non-drug therapies, like the activities and the environment changes and things like that. So it takes that long to see a good response, but you need to be looking. And if after about 4 to 8 weeks, if you are not seeing a response, you're thinking, this isn't working very well, talk to the doctor and maybe they can switch from one flavor to another flavor, to a different antidepressant, and or maybe even add. So you can have 2 different antidepressants that work in 2 different ways. And that's possible too. So if it's not working, be patient and don't give up. And keep going back to the doctor and let them know if it's working or not, okay? Because they can adjust the dose up or switch the dose, switch to a different drug or add another drug. So, those are the different strategies that we could try. Next slide. Oh, the other thing, right, is that medications have side effects and drug interactions. And we have some of these guys, I guess some of the graphics didn't work here, but some of them get more sleepy, more confused, more depression. Some, they're used to treat depression, but they can have more depression, right? Or get anxious or agitated, restless or dizziness, anything like that. Pay attention, because once they start these new drugs, and you notice within the next few days that something is not right and they're getting worse, you need to let the doctor know. You have to monitor for side effects. And so that's why your main approach should be non-medication care. And we're going to go into depth with that next month. Okay, now have you noticed some people are very grouchy, right? They're resistive to care, combative, screaming, they curse at you, they're irritable, they don't let you do anything, right? These types of behaviors that we see in our residents, these could be depression in disguise. When people are really depressed, this is what they do. It's not just being sad and crying. Sometimes they can be quite aggressive. So, but don't just jump in and give medications to calm them down, right? Change your approach first, see if that helps. And then, talk to the doctor about that, because you know what? Antidepressants can be really effective for this. Next slide. So yeah, so if the approach and the environmental change and activities are not enough, medications might be helpful. And the doctor would, I mean, there are many different types of medications. There's those antipsychotics, like Zyprexa or Spiridol or something like that. And there's also anti-anxiety meds like Ativan. But you know what? We don't like either of those very much. The thing that we feel is the best and the least side effects are actually antidepressants. And so it turns out somebody else did a study comparing antidepressants and antipsychotics head to head, and they found that, you know what, they actually work just as well. So with less toxicity, because the other drugs have more bad side effects. And so antidepressants are probably the better choice to go. And you know what, and besides all those agitated behaviors, they just might be depression in disguise. Look, he likes this ice cream. He likes this flavor. All right, next slide. All right, and then after you treat them, right, then we want to follow them up with a depression screening every few months. Remember you did that PHQ2? Well, do that again. And look, lo and behold, we did a whole bunch of activities and including him and all kinds of things and gave him antidepressant. And look, his little interest or pleasure went down from 3 to 1, only several days and 2 weeks, not every day anymore. And feeling down just once every few days, maybe twice or something like that. So that's fantastic. His total score went down to 2 and he's not in major depression anymore, right? So just like you did last month for us, we will ask you to do this again in January, because hopefully from now until then, you'll be trying all kinds of ideas and thoughts and getting them to see the doctor and seeing what we can do to tweak their medications and tweak their activities and get the family involved to see if we can make life better for them. Next slide. Okay, so I'm gonna let Michaela share a little bit.
Hi, everybody. So I was going to show you a little bit of the data that we got last month from all of you. We had 63 homes complete this PHQ2 and give us data on 140 clients and residents. When we're looking at little interest or pleasure, 71 clients didn't show that at all. 39 had little interest or pleasure for several days out of the month, 14 for more than half of the days, and 16 nearly every day. When we asked you if they were feeling down, 75 didn't feel down at all, 24 felt down for several days, 10 more than half of the days, and 5 nearly every day. John, can you go ahead and hit the next slide? So out of the complete responses that we received, there were 125, which was an 89% completion rate, which is really good. We want to see over 80%. There's still a little bit of room there for us to work on. While you're completing these, please make sure that you're filling out every box. But this is a great first collection. And we're really excited to see how it turns out in January. I'll be sharing this again after we do this again so that we can see how your clients are progressing. So the totals were, we want to see clients in the first 2 boxes, 0, 1, and 1 or 2. So 62% or 62 had a score of 0, 32 had a score of 1 or 2. 26 had a score of 3 or 4, and 5 had a score of 5 or 6. So the ones that have scored 3, 5, or 6 are the ones that we want to pay a little bit closer attention to. John, next slide. We really want to thank you for your feedback this last couple of months. These scores are something that are really great for you to watch. They give you an indicator for how your residents are doing, and then you can act on it. You can talk with your team and modify the care that you're getting, like Dr. Wen was talking about today. Next slide. So thank you for caring. Thank you for caring for your clients. Thank you for caring for yourselves and your family, and we really want to wish everybody a happy Thanksgiving. Now we're going to be getting into the evaluation portion of this again, which I know is everybody's favorite. I really, really want to thank everybody who completed the PHQ-2 last month and everybody that completes the evaluations every month. They're really important for us and for our grant funding so that we can continue to provide this to you for free. If you did not complete your PHQ-2 last month, it is not too late to do it. You're going to go and complete your evaluation like you always do. I will put the link in the chat box right now so you can start that. And when you are done doing that evaluation, you're going to get an email with a link to the PHQ-2 if you want to complete it. In that email, there's also a document that you can download and print so you can do the PHQ-2 on paper. John, go ahead and go next slide. If you want any help with evaluations, if you have any questions about the PHQ-2, you can join me on Zoom. I'm hosting Zoom sessions at 10 a.m. and at 2 p.m. tomorrow and at 2 p.m. on Monday. In that email that you're going to get after you complete your evaluation, there's a Zoom link. You just click on it at 10 a.m. or at 2 p.m. tomorrow or at 2 p.m. on Monday, and I will be on so I can answer any questions you have on the evaluation or the PHQ-2. That is it. Thank you so much, everybody, and I hope everybody has a great holiday.
Great.
Okay, they're getting an error with it, so I'm going to re-enter the link. It was probably typed in wrong, sorry.
Okay, and if anybody has any questions about the presentation today, about depression and treatments and, you know, things you just want to know about that, yeah, feel free to just ask. Maybe you have residents who are severely depressed and you don't exactly know what to do, you know, or you haven't, maybe they are on medications that have side effects you want to talk about. I'm happy to talk. Oh, hi, Juanette, you made it.
I did. Yes, Dr. Wen. Thank you so much. Sorry, better late
No.
than never.
Oh, no, that's great. It's always good to see you.
Thank you.
Anybody have anything they want to talk about?
I think everybody's got turkey on their mind. I think we're consumed about getting ready for the holiday season. I know we've got 50 million things, and the last thing we want to worry about, although it's a very pertinent topic, is depression. Yes, every time we go through something with you and you update us, giving us, yeah, go ahead.
Yeah, before you joined, you know what we talked about? How everybody was too tired to do Thanksgiving. And that's the honest truth. And so we talked about everybody has permission not to cook for Thanksgiving, just to take out.
Or we're all coming over to your house, right, Dr. Wen?
I don't know if I'm cooking, you know.
Is Tanya on? Maybe she can share some of our resources from Alzheimer's Association. Tanya, you can speak. I see her on.
Oh, there's a question.
Can you hear me?
Oh, yes.
Hi, can you hear me?
Yes.
Hi. Yeah, I actually sent those resources to, oh gosh, I sent it through email just about 30 minutes ago. And it's just basically person-centered care and those type things. I don't know if you got it, but I'm not able to share it right now. I'm so sorry. So
okay. We're
person-centered
gonna put
care,
it on our
I'm
website.
sorry, I'm having trouble hearing you.
Yeah, no, I said, we're gonna put it on our website, whatever you sent us, we're gonna put it on our website and they can get to it whenever they can.
Okay, yeah, it's on person-centered care and then on behaviors. And what's important with person-centered care is just having something where everyone can see what is this person about, about past, what their interests are. And a lot of times if you have that in one spot, maybe in their closet, hidden kind of in the closet door, depending on how big your facility is, you want to be careful about confidentiality, but just a place where everyone that is helping the person with dementia can help the person, kind of everyone that helps the person can know the person and know what kind of things that they like and enjoy. And I think that definitely makes the caregiving part a little easier. And then communication too, learning how to communicate and making sure that you join their reality and not try to convince them of your reality. So those are really important top things to really think about to make a smooth and kind of peaceful stay, and too for you, just have that peace for you guys too. But yeah, just the person-centered care. And it's I'm sorry I'm not able to share that through the link right now, but looking forward to our support group as soon as we can get that going. I think because of the holidays, it's just been really hard for our other support group facilitators to join us, but we have not forgotten about you guys. Know that this is something that you really want, and we really want to help you. So we were not able to do that today, or I think it was today that we were going to have a support group, but would definitely want to do that in the future, and we're thinking of you. And thank you so much. Oops,
No,
hello, you there?
Yes.
My internet's a little bit unstable, sorry.
Yeah.
Yeah, so if you need me, my number is 808-518-6651. If you need to reach me directly.
Thank
All
you
right.
so much. And we
Thank
appreciate
you.
the offer from Alzheimer's Association to provide support for our care homes. Thank you. I have a really great question here from Isabel. It's hard to evaluate because they can't talk in English. And then when somebody translates, of course, they don't have anything to say. Everybody sees that all the time, right? They don't know, you know what? And it's very cultural. Nobody's going to ever admit they have depression, right? They don't. They just, that's why I said it's in disguise. Yeah. Depression is oftentimes disguised. And sometimes, we just have to observe. And you guys are really good at this. It's not just talking, right? You can observe them and see, are they not eating well? Are they not sleeping well? Are they, refusing things? Are they getting agitated? So there are things. So that's why that PHQ-2 is not just, what you ask them and what they tell you. It's also what you observe. So those are really important. Yeah, if it looks like they're not interested in activities and they don't find interest and they never smile at you whenever you try to engage them, I think that you can tell. All right, anybody else want to share any challenges that you have? Do you have residents who are super depressed that you never really know what to do with? Are they on antidepressants?
Hi, doctor.
Yes.
I have a question because is this is regarding about my patient. He become confused when there was a medicine given to him, but that medicine is to make his appetite good. Is a 10 pounds lost weight for 1 year is very concerning. It's like from 136 to 126.
Mm-hmm.
So the doctor prescribed mirtazapine.
Yes.
Mirtazapine make him agitated. I told him already the first time he prescribed that, but he did it again. And this time I said, maybe I'm gonna observe it. So taking the medicine take for like 5 days. And then after 5 days, I cannot handle anymore. I mentioned it to the son. The son emailed the doctor. They told me to DC the medicine. But after I DC it, for example, I DC Monday. The patient fell down on Friday. So we ended ER. It was discharged. Everything is okay. And then yesterday, the doctor told me to bring him to ER because the behavior never changed. He's different person now. But the mirtazapine is already stopped. So um they give quetiapine.
Yeah. Ooh.
So
Yeah. So that's why, remember that slide I talked about? It's so important to check those side effects. We try to give medications. Actually, I try not to give medication, right? That's always the best. But if you really have not much choice, because you're not getting anywhere with all the other interventions, then I think it wasn't unreasonable to try the mirtazapine, because that does have a side effect to increase appetite. However, I've had patients, I tried to put in mirtazapine to increase appetite and they get so sleepy they don't eat anything at all.
oh
Right?
wow, I
Then
wish
what's
it's
the
like
point?
that.
Right? Then what's the point of giving that if it's not, they're too sleepy to even eat, right?
I
Or too
wish
sleepy.
doctor is like that, but the other way around. She become restless.
Agitated, right? And some antidepressants, what we call paradoxical, they're intended to help decrease depression. They get more agitated. Then you have to stop it, right? You need to, I'm glad you reached out to the doctor and you have to give them the data. You said, okay, this is specifically the problem. This is specifically, this is how bad it is and how often it is. I don't think it's safe, you know? And maybe what they can do, and I don't know what it is they can consider stopping it or cutting the dose.
Oh, they decided to stop it, doc. So
Yeah, I know. Sometimes you can, cut the dose in half, sometimes they tolerate it better if that's the case, but really you need to, you're the front lines, you need to see, wow, if it's side effects, then that doesn't work. We have to try a different flavor of ice cream.
right. But doctor, is that losing 10 pounds for 1 year very concerning? The patient is 90 years old.
It is. And so definitely need to
Okay.
talk about that. I'm glad. And maybe it's from depression, but maybe it's from something else too.
Okay, doc. Because I also take care of my mother before. No matter if it's your loved ones, you cannot afford that. You're eating and then they're not eating, yeah, because it's your mother. Then it's different. They said, but no, I feed my client like what I eat. So I want them to be healthy because the more healthy they are, the longer they live and the longer money I'm gonna have. Right? Rather than why are you depriving them from food? Food is so cheap. And then he don't want to eat. I said I can buy every day his favorite if that's what he want. But the thing is, he's just like gonna say no, no, no. I'm gonna offer him every 2 hours, 3 hours. No.
Yeah. So yeah, that's a whole other discussion about getting people, problems with losing weight and appetite. It may be due to other things, not just depression. And you can take a look at that. Could be maybe you have trouble swallowing or chewing, or maybe the dementia is progressive. They don't know how to feed themselves very well and they need actually help or assistance, or cueing for swallowing. There's a lot of other reasons why sometimes with losing weight. So that happens. So if that's
Yeah,
concerned, need to talk to the doctor, and the doctor can work on trying to figure out what is the root cause of that. Yeah.
right. Because doctor before he wear denture, yeah, up and down. So I said I think it's distracting the denture. So I decided to take it out. It went better. And then maybe I can feed him puree again. So we did the puree and he's gonna tell me, what is that? What is that? No, no.
Yeah, I know, right? Different textures too.
Plus
For some
been
people,
feeding
change
him.
the texture helps. Sometimes makes it worse.
Oh,
Everybody's different.
and
That's what.
already spoon feeding dog. So I don't know what to do now.
Yeah. Well, you know what? That's why we all have a community here, and we all have to ask each other questions and see how you dealt with it. How does somebody else may be very creative and did something very sneaky
Oh yes, yeah,
that we can
that's
share. Yeah.
thank you, doctor. Thank you.
Does anybody else have any comments?
Dr. Wen, this is Mary Val.
Yes.
I had a patient before and his dementia progressed, but that was my first patient, so I had to consult case management and doctor to determine whether it was the dementia that was the causing factor for the not wanting to eat and the loss of weight. So they eventually sent nurse practitioner to come in and evaluate, and they did rule out the fact that he is actually showing the more severe stage of dementia. So therefore, they had to classify him as hospice at that point.
Hmm.
And so on my point, because he was my private patient, I had to make sure I had to keep him alive. So I would worry, I would keep wanting to feed him almost like every 10, 15 minutes, because he would chew it, but then he forgot how to swallow.
It. Yeah.
And then I don't want to keep giving, and then he would choke, and that's even a much more dangerous situation. So I would what I would do is I would trick him at the very beginning of the morning, and I said, because he likes eggs, so I would poach an egg, and then he can't taste the egg anymore. So I would put a pinch of salt in there just to kind of wake up his taste bud, and he was able to take it. And if he eats that one egg that day, I was happy, because sometimes 2-3 days he wouldn't eat.
Yeah. And you raise a very good point. With regards to end of life, at some point, people can progress to very end stage disease. And even with not end stage disease, I think our focus really ought to be mostly is quality of life. Whatever life they have, we want them to be as happy and
Right.
peaceful as possible,
Right.
So the food, they don't have to eat a lot of food. They just have to
Yeah.
enjoy the food that they eat, even if it's a small amount,
Right.
they just enjoy it, right? Yeah. And the other thing is, if they can't eat large amounts, and this is for Josephina's a point, if they don't want to eat it, then you have to give them high calorie dense food. So instead of, so you have to kind of pack in all the nutrition in a very small amount. So try and ensure with added things to it, ensure with added smoothie and added,
Well, that was the beginning part. That was the beginning part, doctor, where we ended up giving, supplements like that, like the Ensure, and then ice cream. So anything that it was high caloric,
Yeah.
I would give. But at the very end stage already, I was happy if he was able to eat a whole egg in just 2 days apart
Yeah.
or 3 days.
Yeah.
So
I think
I
that's the
mean,
thing.
they will forget.
Yeah. I think focusing on that quality of life is really important. So yeah, salt to the egg, that sounds good to me.
It's
Some
not
people love
really,
salt.
well, it's not really good, but then what can you do? He lost like almost like 30 pounds already. So I don't think that the
Yeah.
pinch of salt would matter at this point, because the doctor's goal was at the point, and that time was like to just give him what he can tolerate already, and just
Yeah.
that.
All right. So I think we are at the 3 o'clock, and sad we have to stop, but it sounds like we should do another session sometime on weight loss and problem swallowing. One of these days we'll
Yes,
should do
doctor.
that. Yeah. Okay. Are there any topics that you guys, so when I prepare the slide, right, I'm trying to, go through our series, but I also want to give a little bit of stuff about COVID. Are there particular COVID topics you want to hear about?
Did you discuss about this them recommending visitation for nursing / care homes and foster homes
Oh yeah.
that John
And
had sent
58.
out? You did? Okay.
Not too much, but I think that what I did recommend, and what I said is no social isolation. We're done with that. We need to have people interact with their families and their loved ones, but we have to do it safely. We have to do it safely. Now, the nursing homes, they have these new mandates from CMS that they have to open up, and they have to allow all these visitors to come in. You cannot block them if they're not vaccinated or vaccinated, and all kinds of rules like that, which quite frankly concerns me quite a lot. But it actually doesn't pertain to care homes. So maybe you guys are off the hook with that, and I would say maybe.
No, I have to go ahead and interject because Justin from DOH went ahead and sent out an email yesterday, basically telling us that he would highly suggest that we do follow the CMS guidelines.
Okay.
He sent out that email yesterday. So
Okay.
that's why I wanted to address it.
Okay. But I will tell you that you do have options to be safer, right? Because, we live in Hawaii, and, it's not like we live in Vermont and we can't do outdoor visitation. If you were in Vermont, you have to be indoors, right? And you got to take off your mask to have it to eat, but here, as much as you can do outdoors, I would do it.
Absolutely. That's what I recommend to all of my ARCA members.
Yeah. And also if you can, and it also means, you need to sort of plan ahead. So you kind of stagger and plan so that not everybody shows up at the same time, right? Because then you have the social distancing problem, right? I mean, a physical distancing problem, because, your home is not that huge, but if you could plan ahead, then, you got a couple hours for this family, then next family and next family, and then you can spread it over days. And it's better to celebrate over a long time than a short time. And some of the ideas I talked about earlier is that, families they can show they care by sending treats, by sending pictures, by sending videos, by sending drawings, by, all kinds of different ways. You don't have to do it all at once, and you don't have to have 15 family members show up for one party, So being able to space it out, and I think we can do it safely. I think, and also as much as we can talk about vaccination and how it lowers rates of hospitalizations and deaths. There is that fourth surge going on the mainland, even among vaccinated states, highly vaccinated states, but their hospitalization and death rates are very low if they're vaccinated. So definitely talk about it and encourage that even if they're doing visitation, to continue wearing masks.
Right, the protocols that Audrey had set up last year, we should still follow them. That's a good guidance.
Yeah, the virus didn't change its mind, actually. The virus is this, actually more contagious at this point. So I think always better to be, it doesn't mean stop visitation, it just means do it safely. So I hope you guys have a chance to share amongst each other about and ideas and questions about how to do this safely.
Well, as always, Dr. Wen, we appreciate everything that you do for us. I wish everybody a happy Thanksgiving, and yeah, keep safe.
Yeah, I appreciate everybody also. And thank you so much for carrying on and doing your good work. Happy Thanksgiving. We are thankful for you.
Thank you, Doc. Happy Thanksgiving. Aloha.
Okay, bye.
Bye.